We move on to the next segment, that's clinical challenges in day-to-day practice. May I invite Dr. PRIYA CHOCKALINGAM from Chennai. She is the founder and clinical director of Cardiac Wellness Institute, and she'll be speaking for the next 11 minutes on cardiogenetics and preventive cardiology, the new frontiers.
Very good afternoon, ladies and gentlemen, respected chairpersons. Again, it's an honor to be invited to talk at this important conference. Thanks to the organizers, especially to Professor Chopra. The topic that I'm going to be touching upon is cardiogenetics and preventive cardiology. So, though relatively new, I would say cardiogenetics is an upcoming field in India, and I'm really excited to be able to share some of my experience. So what is sudden cardiac death? Any death in an individual within an hour of developing cardiac symptoms is termed as sudden cardiac death, as you would well be aware. And causes are typically either multifactorial diseases. For instance, coronary heart disease and congenital heart diseases would come under a multifactorial group, whereas single gene disorders or conditions transmitted genetically. Examples are inherited arrhythmias such as long QT syndrome, Brugada syndrome, and also the familial cardiomyopathies, that is the inherited hypertrophic cardiomyopathy, the dilated cardiomyopathy, and the entire range of cardiomyopathies. So how do we prevent sudden cardiac death from all these causes? So this is the big concept or the theme from which I'm working at the moment. Sudden cardiac death in various age groups has been very nicely demonstrated in this picture here. So if you look at the younger age group, infants, it is predominantly the primary electrical diseases or the inherited arrhythmias that I just mentioned. As you move up the age ladder, you have a combination of cardiomyopathies. You have acute myocardial infarction setting in around middle age, 30 to 40 years. Of course, unfortunately, it's proving a lot more challenging, because these days we even see very young people with acute MI in their second decade of life. So again, this is just a helpful diagram, helpful picture, but we cannot completely go by these age groups. And of course, in the older age group, we have the ischemic cardiomyopathy leading to sudden cardiac death. It is interesting that the prevalence of these diseases also varies. So it's about 0.005 to 0.2 per thousand individuals per year in the less common diseases like the cardiomyopathies, the electrical abnormalities, whereas we already know that the sudden cardiac death due to myocardial ischemia and damage is much more common than the other diseases. But again, this is a spectrum that we are looking at. So briefly to touch upon the genetic mechanisms of cardiomyopathies, we know that these are primarily sarcomere gene mutations in the HCM and the DCM group, whereas in the ARVC or the ARVD, arrhythmogenic right ventricular dysplasias, it could be the desmosomal aberrations. LV non-compaction cardiomyopathy is less clearly understood entity, but again we do know of specific gene mutations in this condition as well. And to touch upon the inherited arrhythmias, so what is causing these arrhythmias is genetic aberration leading to abnormalities in the ionic channel. So we all know that the cardiac action potential is a delicate balance between a group of ions moving in and out of the cardiac myocyte, the sodium, the potassium, the calcium channels. If there is an abnormality in any one of the genes in these ionic channels, we get a range of abnormalities in the electrical current of the heart cells. So typically there are loss of function or gain of function mutations in these electrical conduction diseases. So how do we diagnose? These are rare diseases. How do we come to a diagnosis? There are typically some clues. So if there is unexplained sudden cardiac death in the family, aborted cardiac arrest in a young individual, if there's syncope, any palpitations, any incidents of drowning, unexplained drowning in healthy individuals, arrhythmias, especially the ventricular arrhythmias, torsade de Pont, for instance, And of course, unexplained seizures. Very often there have been a lot of cases of long QT syndrome, for instance, have been misdiagnosed as epilepsy and have been undergoing treatment without much response, and then after a long time come to the attention of a cardiologist and an ECG is done at a late stage. Anyway, so these are some clues that should ring a bell and say that, does this patient need an ECG early on? An electrocardiogram quite often helps to rule in a lot of these conditions. And again, the management flow is multidisciplinary here. We have to start with a very, very clear and elaborate family history in these patients, because if we ask one or two questions, anybody early death, anybody with MI, you get one or two pointed answers, and that's not enough. At least a 3-generational pedigree chart has to be taken to understand if there has been any early death in the family, any history of syncopes, palpitations, any pacemaker insertions for no definite etiology. So these kind of things have to be elicited, and this could involve a genetic counselor. Quite often in the West, this is done as a teamwork because the clinician is quite busy, so it's unlikely that they have the time to elicit a very detailed family history, but that's a very important step nevertheless. And of course, all the clinical investigations such as blood investigations, imaging studies, if possible the stress test, that is the treadmill test, or provocation studies, drug provocation studies like epinephrine tests. So there are a range of tests which need to be done, and only if there is still a good, clear suspicion of an inherited arrhythmia syndrome, then we proceed to go to the genetic testing. And in case this individual is already deceased, again, the molecular autopsy is a very important clue. It gives a clue as to how do we come to a conclusion as to the diagnosis in this patient, even though he's no more, he or she, but then the rest of the family could be screened early and sudden cardiac death can be prevented from that molecular autopsy. So moving on, so this entire armamentarium of tests should lead us and help us to give an accurate, near accurate diagnosis, at least if possible, for the family. How do we treat them? How do we first risk stratify this family as to which is the condition? What spectrum of the genetic variation do they lie in? Because the same gene, the same abnormal gene will not manifest with similar phenotype in a couple of family members, for instance. So this is a phenotypically and a genetically heterogeneous disorder that we're talking about. So we need to screen all the first degree family members to begin with, and then move on to the second and third degree family members as well. So there are treatment implications. So gene-based therapy has now become the standard of care in these individuals, particularly if it is long QT1, then we know there is beta blockers which are extremely effective in treatment. Whereas in long QT3, for instance, beta blockers are not that effective, and if it is a malignant presentation, we would think directly of an ICD, an implantable cardioverter defibrillator. And somewhere in this range is also the left cardiac sympathetic denervation, a surgical technique that we do to prevent the arrhythmogenic trigger in these patients. So as I just mentioned, a cardiogenetic team work is very key, very important in managing the patient as well as the family with cardiac genetic conditions. And each and every member has to play their role very well and regularly have a cardiogenetic team meet to be able to make the difficult diagnosis, to see how better to manage a family and so on and so forth. So one example of a case here is a 4-month-old female child who presented with very severe arrhythmia. It looked like a ventricular arrhythmia to begin with. She became limp and unresponsive, was brought to the hospital, and on arrival she had very broad QRS complexes. The regular investigations were normal, so this was an unexplained ventricular arrhythmia in an infant. And however, the family history at this point was not very helpful. There was not much of a clue from the family history. But because I was working in the academic medical center in Amsterdam, where I did my PhD in cardiogenetics. So again, this was a referral center for cardiogenetic conditions. So there was a high level of suspicion for an inherited arrhythmia to begin with, and this child was resuscitated, was subjected to genetic testing, and not surprisingly, there were 2 different sodium channel mutations identified in this young child. And again, going back into the family history, this child had a brother who was about 4 years old at that time, and his ECG also had some aberrations. It was not a completely perfect ECG. I'm sure it's a bit difficult to appreciate from there, but sodium channel mutation has a Brugada kind of a pattern in middle age and on, but in younger infants, younger children, it is not a clear-cut Brugada type of ECG that we see. We see some abnormalities in the PR intervals, some QRS prolongation. So this type of ECG was also seen in the older sibling, and he also underwent genetic testing and was found to have a similar mutation. And the father was the carrier of this mutation. The mother was normal. So again, though we learn from textbooks that Brugada syndrome is typically a disease of men in their 40s, that is in the middle age, these are just helping us in a way, but we have to expand our clinical knowledge and suspect these diseases even in a younger age group. So now switching gears, so looking at the ischemic heart disease burden, this is the most important cause of sudden cardiac death the world over. And looking at the burden in India, especially the dark red color, so we are at a high burden of men and women of ischemic heart disease. So this is a known issue. However, it's very interesting to note that I'm going to be done in a minute or two. So non-communicable diseases, most of them are caused by 4 abnormal health behaviors: tobacco use, unhealthy diet, physical inactivity, and harmful use of alcohol. And unfortunately in India, again, if you look at the red, dark red, we are at a very low physical activity level compared to most of the other countries. Less than 0.24 meds per week, so that's extremely low. So again, at Cardiac Wellness Institute, we have gathered some data on primary and secondary prevention. So the risk factors that you look here, are able to see here, appreciate, there are extremely high levels of behavioral risk factors such as psychosocial stress, dietary insufficiency, exercise insufficiency, again the metabolic syndrome, hypertension, diabetes. So all of these, the 9 traditional risk factors that we are now aware of, are extremely high in our population in Chennai as well. I come from Chennai. The proportion of patients with multiple risk factors is again very high. So the middle bar column is the 4 to 6 risk factors. Predominantly, most of them come at least with a set of 4 to 6 risk factors. Very few have 7 to 9, and very few have just 1 or 3 risk factors. So this is, we are dealing with a group of patients who have a combination, multiple risk factors. So cardiac rehabilitation and primary prevention. So this kind of programs become extremely important, where it is both an exercise and education combined program for these patients and their families. So we do provide these kind of cardiac rehab services at our facility. Again, there is enough evidence out there to show that cardiac rehab, when provided appropriately and systematically, really has a mortality and morbidity benefit, as you see here in the Kaplan-Meier curves. Again, there is also a difference whether they attend more number of sessions or less number of sessions. So the cutoff is 24 sessions here. But it's very clear that even a few sessions, if they're able to attend, there is a good improvement in mortality benefit. And again, in our program, the last 1 year's experience, we have had very good outcomes in terms of angina reduction, an improvement in BMI, waist circumference, functional capacity, especially within a few sessions of 6 to 8 sessions, they are able to demonstrate improvement in functional capacity with a simple test, the 6-minute walk test. Of course, we've also used the treadmill test. Both of them, they show difference in their comparison between a pre-program and a post-program. So what are the key take-home messages here? Again, we have to be scientifically inclined. All of us have a lot of data. We do a lot of excellent clinical work, but scientific publications and able to compile our data into presentations and publications becomes very important in the international scenario. And last but not the least, these are all, as I mentioned, a combination of factors produce these diseases: lifestyle, environment, as well as genetic. And how do we prevent? The solution is in individualized programs for patients, clinical and research collaborations, but especially for rare diseases. There is no way one setup, one clinician can do it all by himself. There has to be a national collaboration and, if possible, international work as well, and meaningful healthcare policies when it comes to preventing these huge burdens to healthcare. Thank you so much for your patient listening. I would be open to questions, if any.
I have a question for you. I have a family, I'm from the UK.
Yeah.
I have a family in London and they're all athletic. A 13-year-old who was training at the time, she is a triathlon trainer, and she collapsed on the training ground. The day before she was perfectly okay. All tests was done, they couldn't find any cause. Then her uncle, who was also an athletic person, had sudden cardiac death. And I've just had a text recently, today, another one in the family has had sudden cardiac death. At post-mortem, when they've looked for the test, they've just found magnesium and calcium deficiency in the myofibrils. But ECG was normal, everything was normal, they were fit, healthy, had excellent diets. Any suggestions?
Thank you so much, respected chairperson. So this is typically how a patient would, with an primary electrical abnormality like an inherited arrhythmia, would present. So adrenergic stimulated arrhythmia, so those which are during exercise, during activity, during training. So we've had kids who've collapsed in the football field, who've drowned while they were good swimmers, but they had a sudden episode of drowning after diving. So these are quite typical cases, and as you rightly pointed out, the family history is now showing up. So you said there was a maternal uncle who died, who had a sudden cardiac arrest, and was he resuscitated?
No one was able to resuscitate.
So they lost one of the child's family members. So I'm really surprised that, and did you say this was in the UK?
Yeah, I'm from the UK.
Okay, and was this patient also in the UK?
Yes, they're all in the UK. And I had a text this morning,
Okay.
another one has just died.
In the family?
Yes, in the UK.
Okay, so was there a post-mortem, like a autopsy done, meaning a genetic autopsy where they were able to collect DNA from this child and send it for genetic testing? Was a genetic testing even in the investigation profile till now?
Everything was done, they couldn't find
No.
any cause, except in the myofibrils of the uncle who died, there was calcium and magnesium deficiency.
So that is probably a microscopic test again, that was not a genetic test. So this is how they present. Most of their clinical picture is normal, their ECG is normal. I'm not sure if any of the family member has had a treadmill test, a stress test, because if it is CPVT, for instance, catecholaminergic polymorphic ventricular tachycardia, everything is normal at baseline, but when that individual is exercised, they have these typical bursts of arrhythmias which come during exercise, and suddenly they will stop as soon as the person stops exercising. Of course, if it is severe arrhythmia, they would collapse on the treadmill, so they have to be done under very strict monitoring and supervision. So this could be, as I said, CPVT, this could be a long QT syndrome. Unlikely that it is a Brugada syndrome because it is not associated with activity or exercise, but again, here there could be an overlap. So Brugada and long QT could overlap in the same family, in the same individual. So I would strongly suggest a complete family pedigree chart to investigate for any sudden cardiac death, any fetal loss, any newborn loss, even SIDS, sudden infant death syndrome could also be one of the manifestations of this disease. And then to go ahead with screening the immediate family members, first with an ECG. The clinical tests have to be done in the parents, in other siblings, if possible, grandparents, uncles and aunts, the basic tests, the ECG, echo, if possible, treadmill test, and then with that evidence move on to do, if possible, a targeted. If you're looking at some ECG showing prolonged QT interval, then you're quite sure that this could be one of the 13 long QT syndromes. There are 1 to 13 long QT syndromes which are known. However, long QT 1, 2 and 3 are the most common. So again, if it's a CPVT kind of picture, then there are specific genes that we can look for. So each of them have targeted genes. Or if we are not sure, there is a 40 disease or 40 gene panel that they now do to look at the different causes of sudden cardiac death which could have affected this family. Again, a genetic test is not the end all of everything. It does not always 100% give a definite answer, but in most of the cases we do get an information out of which from that we can prophylactically treat the other siblings in the family, the parents for instance, or other members who might be at risk of sudden cardiac death.
Thank you, Dr. Priya.